blepharitis, all these things can cause a spillover conjunctivitis onto the cornea. So, what are the classical clinical features of a viral conjunctivitis? Punctate epithelial erosions or multiple superficial erosions. Erosion is not an ulcer. It's a small erosion. Means you can see there's a small discontinuity of the corneal superficial epithelium. So usually their defects are very small in nature. Their onset is frequently acute, and then they cause considerable pain and lacrimation. So if a person is suffering from pain and lacrimation, and the onset is acute, yesterday there was nothing. Today I have a lot of pain, watering, and that's called lacrimation. Then having photophobia, such kind of thing. You'll have to usually it does not. You should be careful to examine the cornea with the alpha dye, where they will stain the epithelial erosions. Therefore, you can treat with the non-specific lesions, non-specifically, and these recurrences are very common. So, there's something called as recurrent corneal erosion syndrome. Morning time, when he opens the eye, the person will have small erosions on the cornea, and then after some time, the photophobia and all these things will increase. So will have continuous pain, and then when he closes the eye, it will different decrease. So such kind of thing, patients we must always consider recurrent corneal erosion syndrome. That's a different syndrome, but here erosions are common in cornea because of the virus. So since they are epithelial, they are usually do not leave any scar. So they heal rapidly and usually associate with febrile disturbances. And characteristic picture is seen in trachomatic keratitis. In trachomatic keratitis, you can get it can be just to put a little bit of lubricating eye drops and then antibiotic locally administered antibiotic like catifloxin or moxifloxin will suffice. So usually they prevent the occurrence of secondary infection. Another important thing here is since it is producing a lot of pain, you are not supposed to add any type of steroid drops. So superficial punctate keratitis is what I wanted to talk to you about. It's a little bit deeper, but the superficial to the Bowman's membrane. So they produce small whitish opacities in the corneal epithelium. They usually coalesce and then sometimes they produce bigger opacities. It's called punctate subepithelial opacities or keratitis. Very characteristic feature of a adenoviral infection. All adenoviral infections, we get it in seasonal keratoconjunctivitis is what we call it as, or epidemic keratoconjunctivitis is what we call it as. And these are the things which we can review. Such kind of some punctate subepithelial keratitis. So opacities are usually superficial, and then sometimes they are raised. They take a long time to resolve. And then when they are stained, central area of the cornea is usually stained with the fluorescent, and but the deeper the not stained readily with fluorescent, but they will be readily stained with rose bengal. Rose bengal is a dye. You read about the vital dyes in staining of the cornea. They are given in all the books. Read about them. So epidemic conjunctivitis, conjunctivitis for Tegis and superficial punctate keratitis, all these diseases can produce a similar picture of the cornea. So, what are the principles of treatment? Usually, again, I'm telling you, steroids are the last thing of choice. First thing is you must see that it is free of any staining. When they are free of any staining, whether subepithelial, etc., you can treat it with a mild steroid like loteprednol, along with the antibiotic. So, to add, and there is no specific antibiotic for adenovirus, antiviral for adenovirus. So acyclovir eye ointment or ganciclovir eye ointment is usually used for treating viral corneal ulcers is usually has no effect on such kind of adenovirus. Latest, they say betadine or a betadine solution is giving some significant results in treatment of the adenoviral conjunctivitis. So adenoviral strip test is now available. So whether to you put it in the conjunctivitis sac, and then the strip will tell you that whether the person is having adenoviral conjunctivitis or any other conjunctivitis secondary to other causes. So this is one test which is done in advanced centers now because since the test is a little expensive. You're not having the test, but you need to know about this test. Adenoviral conjunctivitis test. It's also called as adenochrome test or something like that. Now we'll know about the most important and most common affections of the cornea. That is, this will be coming as an essay question for you. I request you to hear properly and write down the important points. So, ocular rheumatic herpes, HSV keratitis, herpes simplex virus keratitis, and herpes zoster ophthalmicus. This is how it looks like. See, herpetic keratitis and herpes zoster active window, active then you get defluorescence. This one is called disciform in nature, very disciform in nature, with the infiltration surrounding. Okay, but all these things will be postponed. So, is leading cause of infectious corneal blindness. So, this is a very important thing you have to learn. It includes blepharitis, conjunctivitis, keratitis, and endocytitis. Not all human manifest herpes infection, more than 95% carry related virus. So, HSV keratitis is herpes simplex viral infection of the cornea. So, it's got widespread distribution, and virus has got some evidence that viruses have got antigenic properties. And then immunity does not develop after attack. So you don't think that once we get the infection, immunity will be happening and it won't come. So you must understand that this goes on recurring. The mode of infection is usually periodic attacks of cold, lips, nose, and cornea with epicellular white type 1. So viral is a viral protein, viral surface glycoproteins are there, envelope tegment is there, and then icosahedral delta hedral capsid is there, and viral DNA. It's a single strand DNA. So you should remember that glycoproteins are the viral surface glycoproteins. They get adhered to the cornea. So what is the virus type 1? Herpes simplex virus type 1 usually involves the lips, nose. Usually lips, nose, you get blisters. In fever, we'll call it a fever blister. They will form at the angle of the mouth, sometimes around the upper lid, and also here at the nose point. And then sometimes it involves the eye also. This is called herpes simplex keratitis. Very important. So primary herpes simplex keratitis, when do you suspect it? And this is blepharoconjunctivitis. And you see there is follicular conjunctivitis. It is a follicular conjunctivitis. You must know what is a follicle. It is an aggregate of lymphocytes in the subconjunctival area. So what is the difference between follicle and papillae will be asked in your examination. What is the follicle and what is the papillae? Anybody, please type down what is the papillae. Okay. The network problem, every time it is the same. So these follicles can give you this particular type of, it is due to viral infection. Okay, follicles where are other follicles present also in trachoma. glaucoma is a condition caused by chlamydial infection. It is now endemic to certain states only, like Chhattisgarh and Orissa, etc. They still have trachoma, but Andhra Pradesh, trachoma is totally controlled. Trachoma is a very important chapter in conjunctiva. You will be you need to know everything about trachoma, right? So herpes virus 2 is usually genital in nature. Okay. So recurrence commonly take place when there is cold, pneumonia, and then relapse of malaria and exposure to sunlight. These things will help the virus to recur back. So these are the things which you have to be very careful whenever you are advising the patient regarding the HSV1 or primary HSV, herpes viral infections. So you don't get that blisters. So what is the clinical importance? Herpes human herpes virus is most common called a latency where virus remains dormant in the cell and periodically reactivates due to the above conditions. That is, herpes simplex virus 2 have an affinity for sensory ganglion cells and therefore called neurotropic viruses. So usually they have a neurotropism. So what is primary herpes? What is primary herpes? Primary herpes is which is usually occurs in children and may manifest as severe follicular keratoconjunctivitis with vesicular blepharitis. If you see small ulcers or small blebs on the lid along with infiltration onto the cornea, then you must ask whether the person is delivered by vaginal delivery where HSV2 can sometimes infect the infant. This is very common to call a primary herpes. Recurrent herpes affects cornea more than the conjunctival. So recurrent herpes is conjunctival, corneal in nature, but whereas primary herpes is conjunctival in nature. So when you suspect a primary herpes, you suspect it is an infant with a follicular reaction, then it has got a follicular type of reaction on the conjunctiva. So there will be keratoconjunctivitis and vesicular blepharitis. There will be vesicles. So epithelial keratitis usually is a manifestation of the recurrent herpes. Recurrent herpes, you can see there will be epithelial small vesicles developing on the lids. So multiple factors, irradiation, menses, emotional stress, recurrent is most commonly causes keratitis. Okay, broadly classified into epithelial and stromal endothelial keratitis. So what is epithelial keratitis? Epithelial keratitis is most irritating of all. It can cause subepithelial SPK, usually manifested the acute irritation, lacrimation, blepharospasm, as if some sand is thrown into the eye. The fellow will feel constant irritation. Then there will be foreign body sensation. Photophobia will be more, and redness will be more, and there will be blurred vision depending upon the stage of the disease. Okay. The most important thing here is fresh drops keep on appearing, and eruptions will be uh, will will leave the cornea nerves exposed, so that causes more and more sensitivity in the person pain. And then what happens here, the most important hallmark is it does not have mucopurulent discharge. It has got only watery discharge. This is the most characteristic distinguishing feature between a bacterial corneal ulcer and a viral corneal ulcer. Viral keratitis. Bacterial keratitis has got mucopurulent discharge, a small ulcer, but here the ulcer has got inherpetic keratitis because a typical form. Usually it involves superficial epithelium. It goes on the epithelium in a zigzag fashion and extend length and sends out lateral branches. In the branches, there is a small terms of bulbs, small terminal expansions. It's called as bulbs. So that is called, it is formed like a dendrite. You must have studied in your anatomy of neurological dendrite. It exactly looks like a dendrite. So that's called a dendritic ulcer. It is what a knobs and dents in dendritic field is found. Now, no other condition is having such kind of ulcer. So dendritic ulcer is pathognomic of herpes simplex keratitis. Remember dendritic, if you see dendrite, that's usually pathognomic. And it infiltrates or break down extremely irritating ulcerative products, and then the exacerbations can occur in weeks and months. So one part of the ulcer uh, stops going and still it goes on branching that most of the viral load is present in the edges and the bulbs of the teeth. So ulcers change with frozen and the margins with the rose bengal. So rose bengal is important. Um, Frequent like arthritis and large confluent ulcers may form. If you leave it or if you inadvertently use steroid, the ulcers will grow and it becomes a uh, licheniform type of ulcer. You need lichen. Dendrite is slender in nature. Lichen, you must have studied in botany school where lichens is like palm, so thick. And then dendrite will be really slender, like a small bent wires, etc. So licheniform ulcer can occur. And sometimes stroma may be implicated and form a disciform type of keratitis. So when it invades the stroma, there will be a lot of infiltration in the stroma, and then it looks round, disciform. Some part of the stroma will be involved, and this is an immunological reaction. It does not necessarily mean that there are viruses in the stroma. Stromal involvement is usually due to an Arthur type of reaction called immunological type of reaction. So, should keep in mind about this stromal keratitis. Okay, endothelitis can occur. So, when I say dendritic ulcer followed by geographical ulcer or lichen type of ulcer, and then sometimes it can produce marginal keratitis and then metaherpetic or tropic ulcer. And these are the four types of ulcers which are formed by epithelial keratitis. So endotheliitis is sometimes inflammation limited to corneal endothelium, the keratic stress on the corneal edema and the desperate spores. This is what you have to remember. This is how the dendritic ulcer looks like. See, classic dendritic lesion will look with the fluorescent staining. It looks like the branching of a tree, slightly raised, grayish and white, with rose bengal, the kinds of infected cells that have undergone acantholysis. On resolution, dendrite-shaped scar called ghost dendrite may remain in the superficial stroma. So you can see ghost dendrite here. So suppose you see a corneal scar resembling this. This is called a ghost scar. That means already the patient has been on antiviral agent, and then it has formed a scar. So this particular dendrite has thickened into a type of geographical ulcer. It is like some type of continent or something like that. Very thickened, like a licheniform. So this is called a geographic ulcer, and this is a yield stage of the ulcer. Okay. The geographical, it looks like a map, like Australia or South America or something like that. Uncommon immunocompromised and topical steroids have long-standing untreated ulcers. So how do you know when to give the treatment to this particular type of ulcers? Is that when the dendrite totally heals, there should be no staining of the epithelium, and then only you can try with along with antivirals, you can put a weak steroid so that the inflammatory part of the stromal inflammation thing will reduce so that the cornea clears up. But they are liable to have a lot of corneal scars. That is very important. So what you are doing is, sometimes it is very severe in immunocompromised individuals where you have to treat it with systemic antivirals too. Acyclovir tablets, 800 milligrams, about 5 times a day for about 5 to 7 days. That's a systemic therapy. Whereas now topical antivirals are available. Number of antivirals. I'll tell you from the oldest to the latest. Antiviral previously 5% iodoxuridine used, 1% trifluridine, trifluothymidine, F3T hydroxyuride. And now drug of choice is 3% acyclovir eye ointment or 3% vidarabine eye ointment and ganciclovir. These ointments are all similar in 3%. Somebody asks you what is the dose of the or percentage of the ointment which you use, you must say it is 3%. And how many times you should use? At least 5 times a day, minimum 5 times a day. Okay. You remember, in antifungal, what did I say? Antifungal nystatin, a drops you have to use hourly. Here it is at least 5 times a day for 7 to 8 days. 7 to 8 days. Along with antifungal, and along with this, you can also add antibacterial treatment to cut down the superficial added infection case. So, topical so epithelial keratitis responds very well to topical antivirals. And prescribed to prevent secondary infection, you can also prescribe oral antibiotics systemically. Oral antibiotics have no role. So to relieve the pain, you must add lubricant drop and also some cycloplegic. So you dilate the pupil, relax the ciliary body. The patient will feel comfortable. Okay. So generally cotton tip applicator must be used so that if there is small crust formation on the tip of the dendrite, etc., that should be rubbed off so that they expose the dendrite proper along with the terminal bulb. You rub it off with a small cotton tip applicator. Then only you put the drops. They will affect and they will be effective very quickly and very effectively. That's why you can use that way. So such kind of early treatment can give rise to early resolution of the case. So that's very important. Topical steroids are generally contraindicated in the early part of the disease, whereas in the later part of the disease, when it is immunological in nature. You see the ulcers are completely healed by doing fluorescein staining. If there is no fluorescein stain, you can give comfortably weak steroids. If there is any resurgence of the ulcer, you must always see that it is also covered with a antiviral ointment. Okay, for disciform keratitis also, what herpetic diseases I study said is, so it is a multi-centric study. For such kind of cases, disciform means that is advanced. It is more deeper in nature. Then it's also involved in the stomach. In such cases, oral acyclovir tablets, 400 milligrams, 5 times a day should be given. Does not also prevent the iridocyclitis and also endothelitis and also the immunological reaction. But along with the topical antivirals, systemic antiviral should also be initiated. So, the very important thing, low dose antiviral should be continued for a long time to come because recurrences are very common and they are very prone for repeated diseases. So, if you want to see that kind of scarring is so big that it impedes the visual, it causes a visual problem. So usually what you do is you can do if the disease is quiescent, you can do a lamellar keratoplasty. That means a small part of the disease epithelium can be taken off and then you can do a fat graft or something like that. Or sometimes most of the time extensive vascularization can occur. If the extensive vascularization is there will be a problem with the vision. So it produces a permanent opacity in the visual axis. So that particular opacity should be taken off by way of complete penetrating keratoplasty given a corneal graft. We'll talk about this more when we are dealing with eye bank. So next we come to zoster. What is zoster? Zoster is caused by the same virus, but it is usually the person has got history of suffering from chickenpox in the earlier days. When the person has got chickenpox in the earlier days, usually you can expect a zoster, Herpes zoster, enterocolitis, and Herpes zoster, ophthalmicus. Two particular things are known. So ophthalmicus is a particular thing which involves the ophthalmic division of the third nerve, and it is usually do these type of zoster will affect those people who are having diabetes or having immunocompromisation, and you are having any debilitating disorder like cancer, etc. These particular zoster virus will go and sit in the Gesserian area, and then they shed the virus through the neural nerves. So they usually affect the travel along the more branch of ophthalmic third nerve, and in the area of distribution marked by rows of vesicles. You can see one half of the individual face will be affected, either right half or left half, where the Gesserian ganglion, and then on the frontal side also it affects this particular branch, and then facial branch, and then the nasociliary branch. If this nasociliary branch is supplying the tip of the nose is involved, it's called the Hutchinson sign. Hutchinson sign is when the tip of the nose is involved, invariably the cornea will be involved. You remember, the tip of the nose is not involved. It does not mean that cornea is not involved, but usually cornea is involved, the tip of the nose is involved. So that is a particular sign which you have to remember. So usually it is a scarring disease. It leaves a lot of scars on the face and the nose and all this particular half of the body. And then in one thing I did not mention in my previous lecture on HSV, you have to check up the sensation on the cornea with a small wisp of cotton. The sensation on the cornea will be diminished in compared to the other eye. It is not lost, it is diminished when compared to the corresponding eye. So all the viral diseases which are neurotropic in nature, they tend to diminish the sensation of the cornea on that particular side. So nasal branch, if it is involved or very rarely intranasal branch, no, very rarely intranasal branch, intraorbital branch. So it usually does not cross the midline. So you can see as one half of the face is involved, and it can be bilateral sometimes. All the whole of the face may be involved in some peculiar conditions called as immunocompromised individuals. Here there will be fever. The first there will be fever, and so simply treatment I told you. So most important metaherpetic ulcer is tropic ulcer. Whereas de novo on a metaherpetic ulcer, what is dendrite or geographic ulcer? Toxicity from antiviral medication. Usually I told you it is a tropic ulcer. Metaherpetic ulcer, and you can be asked as a short notes. Be very careful. So don't write anything about herpetic ulcer. The metaherpetic ulcer is of toxic nature, antiviral medications, lack of neural derived growth factor, poor tear surfacing. Sometimes tear surface can also produce a metaherpetic ulcer. Low-grade stromal inflammation. Neurotropic ulcer start as a roughened epithelium with smooth margins. So you can see there is a metaherpetic ulcer here. Okay. It is not it's a viral ulcer which turn into, after treatment, it may turn into a toxic ulcer or metaherpetic ulcer. So I told you about the endothelitis in the previous class that whereas epizoster keratitis can involve the endothelium. Then can also infiltrate into the antechamber, irritate the iris and then produce a stickiness of the endothelium. So endothelitis and even this endothelitis can also cause tuberculosis. Tuberculosis is a very characteristic feature of herpes zoster, not simplex. Remember, tuberculosis which produces an inflammation in the tubercular meshwork of the eye, thereby raising the intraocular tension, is usually a characteristic feature of herpes zoster. So, whole of the cornea may be involved. It's called necrotizing keratitis. In herpes simplex, then the whole of the cornea will be involved. All the dendrites will coalesce to form a uniform opacification, whereas the vessels from the periphery will come and enter into the cornea and then produce something called as melting and perforation can occur, usually rare in nature in herpetic disease. Because usually herpes simplex is epithelial in nature. Okay, well, let's not get confused. There's so many things. So it goes along according to dermatomes. Zoster, I told you, is trigeminal dermatome and then nasociliary branch and living the virus then established latent stage in sensory ganglia, as I told you. And since you asked me to project picture, see there's particularly this particular part is more involved with a lot of vesicles, scars, and then ruptured vesicles, and then it is involved in the lid, and then you can see that the tip of the nose is involved here. Therefore, if you look at the cornea, you can see corneal ulcer there. Okay. So here also there will be loss of lashes, maybe there is chronic acute complication. But I will tell you important things is that you get fever and malaise. These two things are very important. And where are you going to get the neurological pain? There will be severe neurological pain for 2 to 3 days, as if it's a burning type of pain in particular segments. Suppose person complains of burning pain around this area. That means if you wait and watch for 2 3 days, there will be vesicles erupting in that particular area. If you see any burning sensation in genital area, that means after 2 to 3 days you can get vesicles. If you see any intercostalis burning sensation, burning is very important. Pain is important. These things, if you are done for certain stage, then the vesicle will form quickly on that. So that burning sensation and is very characteristic of that there is a severe neurological pain, neuralgic pain because of the viral activity in the nerve. So this should be remembered, and then soon after that, it should arouse suspicion that the fellow will be developing vesicles. So pain after the outbreak of the vesicle, the pain usually comes down. Fever will come down. But the vesicles, when they rupture, they produce a little bit of pain, but the patient will be relatively comfortable. They become red edematous. Vesicle often separate and bleed. Small pitted scars will be developed. Scars are very, very characteristic feature of Zoster. That's what I said. Such kind of scars usually seen in the cornea in stromal keratitis of herpes simplex virus is seen, whereas this produces scars on the skin also. Okay, they usually form some degree of anesthesia for about 3 weeks. Okay, the lesions which are larger in nature and they'll be round. These are called a nummular keratitis. Nummular keratitis is a characteristic feature of herpes zoster. And then the gray scars will be formed on the sclera patches of sectorial atrophy can develop on the iris. Sectoral atrophy when on the iris will also develop, and cranial facial palsy can occur, and then acute retinal necrosis can develop, and cutaneous vascular infections can also develop. In 5 to 3 months' time, the person will have terrible pain. Post-herpetic neuralgia is what is importantly described. So, what when the invention of acyclovir or a ganciclovir ointment and tablets have greatly reduced the incidence of post-herpetic neuralgia. This is a very, very, very bothersome thing. Even if lesions are completely healed, the person will not have comfort because that particular nerve keeps on aching, and then the fellow will not be able to sleep. So this post-herpetic neuralgia is due to a complication due to virus. And sometimes it can cause acute retinal necrosis. Retina can involve, and trabeculitis can increase the blood pressure, intraocular pressure, leading to glaucoma, which is very recalcitrant to treatment. And then sometimes the optic neuritis is also a complication of epic zoster. So zoster cannot be taken easily. Remember these particular complications whenever you are writing nasty. So 800 milligrams of acyclovir daily. So 5 times a day, 800 milligrams. Huh? It's a severe infection. So acyclovir is the drug of choice. It should be given 8 times a day, 5 times a day for a period of 10 days. It is recommended, not less than 10 days. And then to reduce the period of virus shedding, accelerate the time of the healing by 50%. It takes its own sweet time, but it can accelerate the time by killing the decreasing the viral load. So post-herpetic neuralgia is very much reduced because if you start the drug early, acyclovir drug early, post-herpetic neuralgia will be little, and then usually such kind of things will produce such a ghastly rat. The person usually goes into depression, and the pain intolerance will also come down. So you'll have to put the patient amitriptyline 25 milligrams to 50 milligrams and to reduce the scars. Okay, occlusive vasculitis. You may also have to need to add systemic prednisolone or some systemic non-steroidal anti-inflammatory drugs such as oxybutazone. There's Sugandil previously, it is not available now. We are mostly depending upon diclofenac and ibuprofen. So either of things can be given. So it's if suppose sclera is involved, usually sclera is adjacent to cornea. There is a sclera involvement also. You have to take care about that. So dexamethasone drops and then acyclovir eye ointment and then or systemic antivirals and then sometimes steroids. These are things in neurotropic ulcers are best treated by tarsorrhaphy, lateral tarsorrhaphy. So you close, you take both the eyelids and then underneath the eyelid along the margin, you take a small skin, you peel off a small skin with the help of a blade. You can cut up to the tarsus area, and both the areas can be joined and sew and put a small suture. It's called a lateral tarsus. That will prevent the exposure of the cornea. Therefore, these things can be very helpful in improving the prognosis of cornea getting affected. Okay. Now then, you can be given a short notes on catarrhal ulcer. What is the catarrhal ulcer? Usually ulcers which occur on the limbus. Okay, they usually are in old people. Old people. Catarrhal ulcer another short notes కింద అడుగుతున్నారు. And this is because the toxins produced by staphylococcal organism present in blepharitis. ఏంటవుతుందంటే that blepharitis, the staphylococcal produces some toxin. They get accumulated in the conjunctival sac. When there is a small, the conjunctival will swell, and then this particular there will be a groove between the conjunctiva and the cornea at the liver, where this toxic material will go and sit down. And then they will irritate and then produce small ulcer. So you can imagine that it may be caused by moraxel and hemophilus are also described along with staphylococcus. Then you can only these particular things which are in contact with the eyelids, where exactly eyelids are in contact, that particular area only you get the catarrh ulcers. So catarrh ulcers, you remember, and they are small near the limbus at 4, 7, 10 and 12, 10 and 4. Okay. So there can be involved with the vaginal granulomatosis or immunosuppressive immunological disorders, etc. Treatment is by appropriate antibiotics, and blepharitis will be treated properly. You don't treat the blepharitis. How do you treat blepharitis? You have to give systemic anti uh, antibiotic like tetracycline or amoxicillin cloxacillin combination. Then ask the patient to daily give hot fermentation the eyelids for about 10 minutes and then rub the eyelid down to up and then press on the eyelid toward the eyeball so that pultaceous material will be jetting out of the small orifices on the lid margin, on the gray line, near the gray line. It will be like toothpaste. That's called blepharitis. On that particular thing, you can get Demodex follicularum or staphylococcal infection or moraxella infection. All these infections can occur. So this, unless you treat the blepharitis, you will not be able to treat the catarrh ulcer properly. Okay. Now the second one which comes usually a short note is rodent ulcer. It's called as Murren's ulcer. Murren's ulcer is rare degenerative superficial ulcer. All these things are not included in this. The problem here is, I shall tell you plainly, I was involved in COVID duty for about 3, 4 weeks. Rodent ulcer is usually called it's a chronic in nature and it is rare, degenerative in nature. It is superficial ulcer. Superficial ulcer means rodent ulcer మనం సర్దిలో చదువుకున్నట్టుగా when there is rodent ulcer, that rodent burrows, rat like burrows inside and then leaves the upper part of the epithelium just వేలాడుతూ ఉంటుంది. So where exactly rodent అలా లోపలికి ఇలా దూచుకెళ్ళిపోతుంది. You have particular feet type of lab. So common occurrence, the gray infiltrates will break down into small ulcers and spread sooner or later, and then చిన్న infiltrates వచ్చి then it becomes totally anthracoilous subepithelial వస్తుంది. Usually, this is produced by autoimmune lysis of epithelium, and they release an enzyme called as collagenollytic enzyme. So rodent ulcer is not because of the bacterial infection or anything like that, but is because of collagenollytic enzyme produced by the dying epithelium, autoimmune lysis. So this is an autoimmune disease, and this lyses the corneal epithelium. When the corneal epithelium lyses, the enzyme will burrow through and produce a lifting of the epithelium. So remember this particular point. So it rarely perforates, and intermissions for months will usually thin nebula will be formed over the whole cornea, and slight is greatly diminished. So it is usually superficial nature. Superficial cornea is involved. Underneath there will be infiltration. Then there will be overhang edge. That overhang edge you can immediately identify. And then bilateral movement is usually relentless progression if it is there. It's called the malignant type. And then usually milder unilateral painful form is seen in elderly patient. And then it is usually is a diagnosis of exclusion. You cannot diagnose a More's ulcer on primary basis. You should only exclude all the other conditions which are responsible for the marginal corneal ulcer. So usually it is a marginal ulcer going towards the center of the cornea. Okay. So what is the treatment? treatment is that this type of collagenase type of enzymes are usually supplied through an autoimmune mechanism supplied through the uh, call it as blood vessels. So what you do is you have to cut down the blood vessels. You do a peritomy around the cornea. You'll be cutting down the blood supply to that. Then the ulcers will heal. That is with topical antibiotics and steroids usually effective. Then once the particular the blood vessels are cut, the peritomy is done. You usually put a soft contact lens. That's called a bandage contact lens, so that the ulcer does not the flat does not move with the movement of the lids. Okay. Then I'll go into the time. All these things I told you already in different cyclovir, cyclovir, so many cyclovirs have come. These are all depending upon things. Post-herpetic neuralgia, antidepressant, and mitriptyline, analgesics, and steroids. No effect. Thank you. We'll move on